Colleagues, Dumelang, Sanbonani, hello everyone, and welcome to this discussion about the possibility of making COVID-19 vaccinations mandatory for staff and students at the University of Cape Town. I want to start by saying 4 things. The first is that the final decision on such a policy for mandatory vaccinations can only be made by the UCT Council. The executive will table this matter at Council's next meeting, which is happening this Saturday on the 16th of October. Second, let me say upfront that the UCT executive supports the idea of such a policy. The speakers we have invited to address you today will explain the strong reasons from a public health and occupational safety perspective for making vaccinations mandatory. Third, we are hosting these discussions, the first with staff members, and it's today, and the other with students tomorrow, because we know that making vaccination mandatory is a complex matter, and there are many messages out there making vaccination controversial. This is the time for you to register your arguments, both for and against the proposed policy. My hope is that you will raise your points of view so that they can be considered. It is important that we give all points of view a careful thought. So please write your comments and questions in the chat function. And some of you, of course, have written to me emails and WhatsApp messages about how scared you are that your line manager or senior people in your departments or the establishment, as you called them, you indicated that they will make you pay for your views. So please note that you can make your views anonymously. You decide when you write your comments or your questions whether to give your name or to be anonymous. We would like to hear your views. And my approach is that none of us is intimidated or being made to pay for what they believe needs to be heard by the leadership. So please share it. Finally, you are also invited to complete a very short survey to express your views on the proposed policy. The link is posted in the meeting chat, and the survey will close on Thursday, 14th of October at 6 p.m. After taking into consideration the views that have been submitted by colleagues and students, the executive will form a final position on the matter that will be tabled at Council on Saturday. We have requested 2 colleagues to be our speakers for this morning's session, and it is Professor Linda Gale Becker, who's a co-investigator on the Sisonke COVID-19 vaccine trial, which involved close to 500,000 South African health workers and looked at the safety and impact of COVID variants, including the highly transmissible Delta variant. She brought the motion for mandatory COVID-19 vaccination to Senate last month. The second speaker will be Dr. Reno Mora, and I won't introduce her again. He will start immediately when Linda Gale finishes. And Dr. Mora is the Chief Operating Officer of UCT, and he will discuss what mandatory vaccination will mean from an operational standpoint. And thereafter, I will open the floor for questions and comments and discussion points so that we leave this meeting with a view from the community. Linda Gale, over to you.
VC, and we are delighted to bring some scientific facts and try and answer any questions or concerns anybody may have about COVID-19, our own institution, and the role of vaccination. Next slide, please, Kylie. So, of course, we have all just the last 18 months gone through some extraordinary and unprecedented changes in the world because of this pandemic. Next slide. And I just want to remind people we have been here before. There have been other pandemics, and perhaps the most striking in the last reasonable history is this, the H1N1 Spanish flu epidemic, which occurred in 1918, and 500 million people were infected around the world, and an estimated 50 million people died who were young and middle-aged as opposed to the current epidemic that we are experiencing. Next slide. And I tell you this because what you saw there was some of the interventions that we have had to use up until about January of this year, when vaccines were first brought to the fore. So what we were reliant on, because we were essentially a world that was immunologically naive to the SARS-CoV-2 virus, we were reliant on making sure that we reduced the opportunity for the virus to transmit from one individual to another as much as possible. So these are known as non-pharmaceutical interventions, and as you all know, included social distancing, sheltering in place, particularly if we were elderly or had comorbidities, using masks, gloves, hand washing, and then of course there were those very restrictive lockdowns that included closure of large institutions such as the University of Cape Town. Next slide. Here in Africa, we have seen the epidemic much as they have in other parts of the world, and around the world we've seen 3 different surges of virus that has occurred. So here you see throughout Africa, and there has been sort of a concept that the epidemic is worse in Africa. I think what we caution people on that is that ascertainment may be a problematic factor on this continent. But when we turn to South Africa, next slide, again we see those 3 waves resulting in, when we look beyond the classified COVID deaths, 250,000 more lives lost nationally from natural causes than we would have expected since May of 2020, when our epidemic started. And I do also want to remind you that almost 65,000 of those have been people who would be considered young or middle-aged. Even this year, we've seen more than 50% higher natural deaths than we would have expected over this period. Next slide. So here are our waves, and striking here is that the virus, which is an RNA virus and therefore prone to mutation, has undergone some variation. And there are a number of variations that have been termed variants of concern, and those are what have driven our 3 surges or waves. The first was the ancestral strain, the original Wuhan strain, which has been the template, if you like, for many of the vaccines we have today. There has been a subsequent beta variant-driven wave, and then most recently we've just survived the Delta variant. Next slide. I do want to point out that there are individuals who are more at risk of poorer or more severe outcomes as a result of SARS-CoV-2 infection. So it may be that we could be asymptomatic or only very mildly affected by the virus, all the way through to severe infection resulting in pulmonological disease that results in the need to be hospitalized, go into intensive care, and actually be mechanically intubated. And of course, people have died. So the individuals who are more at risk are those who are older and those who have comorbidities. In particular here, and this is Mary Ann Davies' data, and I want to thank her and the team at the public health group at UCT, who've done some really sterling work and kept up. This is their data showing that people with diabetes have a worse outcome. Other diseases such as hypertension and renal disease also playing in a role. And of course, importantly in this country, other communicable diseases such as tuberculosis and HIV also showing a greater propensity to more severe outcomes and of course death than other individuals in our population. Next slide. So just to drive that home, COVID-19 can be asymptomatic, it can be mild, or it can cause severe disease and require intensive care and possibly result in the death. And we know this happens more frequently in older people, but it has affected and caused severe disease in young and fit people. And we don't always understand why that has happened. Some of this may be an over-exuberant immune response, which then results in an individual undergoing other manifestations of COVID, which may of course include clots, thrombosis, pulmonary emboli, and so on. So there are a number of different ways that individuals can become ill and die as a result of COVID. When severe, it's highly thrombogenic and has an impact, as I say, on multi-organs, and it can cause long COVID, including in young people, this disabling condition. So that, of course, occurs in anyone of any age. Next slide. So we have now got vaccines that are available to us, and there have been a number of platforms that have been in existence for many years, including the human adenovirus vectors, the use of DNA as a platform. Most recently, we have also included into those platforms messenger RNA, although that is a technology that has been in the works for a long time. And then, as you all know, there is another vaccine using the chimp ad, which is in combination with the pharmaceutical AstraZeneca. We do have monoclonal antibodies at our disposal, as you all know, but those tend to be short-lived and very expensive. So on the active immunization side, you see a range of vaccines here that are available in the world. And as you all know, we have now seen billions of doses administered around the world. There are 2 that are being used here in South Africa. If you move to the next slide, Kylie, those will be highlighted. The first is the AD26, which is a single dose. It is easily refrigerated, lending itself to speed and coverage in terms of rolling it out. And secondly, the next slide is Pfizer, which is a 2-dose. It requires more refrigeration, and it is these 2 vaccines that we are mostly rolling out in South Africa today. Next slide. So what do we want to achieve with a vaccine? Well, of course, we hope for long-lasting protection. And even though we may see some viral escape, so maybe a reduction in vaccine efficacy with the modification in the virus that we've seen recently, there is still some immunological support that we get from a vaccine. We are figuring out how long that durability is, and there's lots of conversation, and many of you will know that countries to the north of us have started to boost individuals who may start to see some waning in their immunity because of old age or because of immune compromisation. We also know that vaccines can be relatively easily administered. Here in this country, already over 20 million vaccines given. So it is something that is reasonably easily done, and it overcomes a lot of that demand for behavior. We know that we're all struggling to keep on with using masks and the social distancing, and of course we do want to get back to work, and this is what a vaccine enables us to do. Our first goal is to protect lives. So the first role of a vaccine is to reduce severe disease and death. And then we look for that added bonus, which is to reduce infection and lead to community protection, which I will speak to in a moment. Next slide. These are the variants of concern. Why do we call them variants of concern? Because there are many variations of SARS-CoV-2, but there are specifically a few that either modify the epidemiological characteristics of the virus. In other words, they can be more easily transmitted, or they may cause more severe disease, or may cause more disease in children, which is something we've seen registered around the world in the case of the Delta variant. They also, as I've already mentioned, may have an impact on vaccine efficacy, and certainly that was the case with the Beta variant, the one that caused our second wave, came about in December, January of last year and this year, and definitely had an impact on vaccine efficacy in terms of some of the vaccines that are available. We know that it does work for J&J, and we know that Pfizer has also withstood both Beta and Delta, and so both of those vaccines continue to work despite the circulating variants we have in our community today. Next slide. So again, in the interest of time, I'm just going to point out that all of the vaccines that are currently line listed by the WHO have very good efficacy, particularly against severe disease and death. Next slide, Kylie. We won't go into the detail because next slide. Because I'm aware that we are concentrating on Pfizer and J&J. And here you see both of them really in the high 80s in terms of protecting against severe disease and death. Next slide. And we can carry on. I'm just going to point out that whilst Beta was the predominant variant for many months, most recently, and you see that's the yellow, you see the green coming in now, and that is the Delta wave. That is really now the predominantly circulating variant in South Africa. Next slide. So, of course, it is important to know whether these variants work in the real world, and a number of studies are starting to come through. Here you see a number listed for the mRNA vaccines, Pfizer and Moderna, but also J&J really maintaining its vaccine effectiveness, even despite the Delta. So you see in the New York State, and again, even vaccines such as AstraZeneca managing in the face of Delta, but taking somewhat of a dip because of the Delta variant. Next slide. Now, VC mentioned that we have early on in this year rolled out 500,000 doses of J&J to healthcare workers, and I thought I would just show you that data. We managed to reach these 500,000 healthcare workers, frontline people, over 4 months from 122 sites. Next slide. And importantly here you see, in keeping with the phase 3's 85% protection against death and a 65% protection against hospitalization. Now that hospitalization included a number, not necessarily everybody needing oxygen or intensive care, but anybody who needed to be hospitalized. So being able to reduce that impact, and we do see that it is maintained in the face of Beta and Delta. Next slide. So what is the summary of vaccine performance? Well, the phase 3s tell us that with the ancestral strain, we really see across the board very good efficacy against severe disease and death, and all performed pretty well against overall symptomatic infection. In the face of the recent variants, there has been some reduction in VE against symptomatic infection, but VE performance against severe disease and death has been sustained across the board. Next slide. So, what is the purpose of COVID-19 vaccination? And this is really important for us to get our paradigm straight. The first role is to make sure we keep our essential workforce on its feet, especially frontline healthcare workers. We protect the vulnerable from severe disease and death. And a third objective would be then to prevent severe disease in the general population across the board. And finally, to overcome that sense of immunological naivety, we want to get as many people exposed either to the natural infection, which of course comes with an enormous cost of potential disease and even death, or to make sure, and perhaps as well, and or to make sure that people are vaccinated against SARS-CoV-2. So we're talking mass vaccination in this regard. Next slide. And of course, we have started to see some evidence that this has an impact. This is data that was circulated by the Western Cape government a little while ago, really just looking at a snapshot on a day. What were the admissions like in our province? And you can see the white individuals are the people who are vaccinated, either with cases, admissions, or deaths, compared to those who are unvaccinated. And some months ago, the CDC head referred to this as the epidemic of the unvaccinated, and we are starting indeed to see that even as we roll out our vaccines. Next slide. And we're starting to see impact in countries. So this is data from the UK showing an enormous drop in hospital admissions and death, particularly in the elderly who were vaccinated first. But this is a country that has really had widespread vaccination and is starting to reap the benefits. Next slide. So what about natural immunity versus vaccination? Well, natural immunity definitely does provide protection. And of course, it's a good thing if the individual survives the disease. So if you've had SARS-CoV-2, terrific, you no longer are immunologically naive, but there is no doubt that you can become reinfected, particularly with a variant. So we know that can happen. Vaccination on top of natural immunity increases the depth and the breadth of the immune response. So if you vaccinate on top of previous infection, you get an increase, if you like, a boost and an even better response. And this is being shown now both with antibody immunity and T-cell immunity, so really improving the breadth and the depth across the board. So very worthwhile to do that. What does it mean for community protection? Well, I think this is an important slide because this is what we are really wanting to bring home, is that where there is poor vaccine coverage, the virus will look for gaps in immunity. It will exploit those opportunities. Where there is much better coverage of vaccination, really the force of infection, the viral load in the community is reduced, and that gives the opportunity to really increase protection. Now, one of the questions I know people will ask is, well, do we think that there is community benefit if people get vaccinated? And without doubt, there is now evidence to show, first of all, individuals are less likely to get infected in the first place if they are vaccinated, and they are less, if they should have a breakthrough infection, it will be milder and it will be short-lived. So they have less time to pass virus on to other people. The sum total of those facts is that we reduce the viral load in the community if large numbers of people are vaccinated. And that really is what we are aiming for when we talk about mass vaccine campaigns. So we get that bonus over and above the individual benefit. Next slide. And I do want to drive home that it brings back normality. So here is a country that has really had fantastic vaccination scale up. Well more than 70% of the population has been vaccinated, and they have now removed all COVID restrictions. Admittedly, we'll have to see how things go. Obviously, there is concern about variants, but the important thing is this country shows that you can get back to normality even at the scale of a whole country. Now, we're talking about an institution being able to achieve this, but I think this gives us hope that this is feasible. Next slide. So, we are hoping that comprehensive vaccination at UCT will reduce the force of infection on the campus. In other words, how much virus is actually able to circulate, reduce prevalence, therefore, of the disease and the infection on campus, reduce the risk of severe disease and death in staff and students, reduce hospitalization and time off, and allow staff and students to return to class, laboratories, wards, and tutorials. And if you like, return to normality on campus. Next slide. Now, I do want to point out, this is not new to us. We have had health behaviors mandated in the past. Seatbelts would be an example. Blood alcohol levels would be another. Smoking in public spaces, of course, is another precedent. Next slide. So I also want to remind you, we do mandate other vaccines. So travel in yellow fever endemic areas requires proof of yellow fever. Hepatitis B vaccination is routinely given to our healthcare workers. And in fact, our students have to take hepatitis B for their own protection and their patients. And tetanus vaccine is often given routinely at the time of an emergency room visit with injury. Next slide. In summary, colleagues, COVID-19 vaccines are safe and effective. When taken to scale, they can allow the return to normality of communities, institutions, and even countries. Mass COVID-19 vaccination is the key to getting back to campus, into classrooms, and back to normal. Always better that any health behavior is taken up voluntarily. So without doubt, we are encouraging all of our staff and students to go out and be vaccinated. The hope is most will do so. UCT is now offering easy access, and those who have robust reasons to opt out should of course be heard and considered. But overall, we will only achieve these benefits if we do indeed have the vast majority of individuals vaccinated. Thank you. And I hand over now to Reno, who is our Chief Operating Officer at UCT, and he'll take you through some of the legal and sort of more governance side of this campaign.
Thanks, Linda Gale, and good morning to all the colleagues who are listening to the presentation. I will specifically cover two areas. One, our approach to vaccination currently, and more specifically, what are the legislative prescripts that enable the development of a mandatory vaccination policy. Next slide, please. Linda Gale referred to returning to normality. So, I mean, in reality, we have been living under lockdown, and our South African context is that we have been flexing around Disaster Management Act regulations, and those regulations are essentially about how best our South African nation is able to limit the viral spread. We have lived through 3 cycles, 3 waves, and many cycles of lockdown from level 5 to level 1. We have lived under limitations by the movement of people. We're very aware at the university and in other parts of our lives about the limitations on gatherings. And there's no doubt that COVID has disrupted our South African environment politically, economically, socially, and in our environmental spheres. In living under lockdown at UCT, we recognize that our teaching and learning environment has been disrupted for both students and staff, our research environment, and certainly our social responsiveness programs, and let alone our areas of operation. We know that this impact has been on staff and students at the university, and way beyond that on our families as well. And we have taken an approach of a hybrid operating model. We certainly, for some staff and in some areas, have had on-site in-person connectivity and also remote connectivity. And we have tried to move from low-density campuses to try and normalize as safely as possible in certain areas. We cannot but recognize the major mental health challenges that our staff and students have faced, and we have put in interventions to try and address that. Next slide. It's important that we embrace the legislative framework when considering the vaccination rule. I don't think there's any fear in terms of the legislation. What we need to do is work within its context and within its prescripts. And the 3 areas I do want to cover in terms of the legislative framework includes the South African Constitution and its Bill of Rights, the Disaster Management Act that I referred to earlier on, our own Higher Education Act, and certainly the Occupational Health and Safety Act. And lastly, and very critically, I do want to refer to the Minister of Employment and Labour's direction on occupational health and safety measures in certain workplaces, which was published in June of 2021. In terms of the South African Constitution, and it is a wonderful constitution, we know that, and the Bill of Rights, we know that everyone has the right to equality, the freedom of conscience, religion, belief, and opinion. We also know that the inherent rights are not absolute, and there are allowances for rights to be limited. Yet that limitation needs to be reasonable and justifiable based on human dignity, equality, and freedom. And in addition, restricting those rights need to be proportional to the purpose of the limitation. And so in considering the vaccination rule, we do need to address, as our Constitution requires us to do, limits to fundamental rights. So in terms of limits and freedoms, we certainly will need to address the limits to bodily and psychological integrity, conscience, religion, and belief. In looking at the vaccination rule or mandatory policy, certainly individual freedoms would be secondary to the public good. Next slide, please. I do then want to go on to the next component, and that is the limitations and the rules and regulations related to the Disaster Management Act and the Occupational Health and Safety Act. We are aware, and we've lived through them, that there have been directives and limitations that we have already experienced during lockdown. And just to mention a few, compulsory wearing of masks in public places. We know that our schools have been opened and closed. We know that our universities have had to adapt. We also know, as fundamental as funerals are to our society, that attendance at funerals have been limited, and also movement of people, let alone limitations to gathering indoor and outdoor. We have also been provided with a national framework and criteria on how to manage our academic year within our institutions. And lastly, the occupational health and safety measures have included a risk assessment, which we've had to do, limitations and access to workplaces, social distancing measures, and clearly in terms of our own app, symptom screening. We've also addressed issues of ventilation in our venues and clearly provided personal protective equipment, just to mention a few in terms of that act. Next slide, please. In summarizing what I've just addressed, UCT, I think, has 4 key obligations. We are a public institution, and we have a duty to protect, to promote, and to fulfill the rights in the Bill of Rights. We have an obligation to protect our staff, students, and all visitors, as everyone has a right to a safe working environment. Everyone has a right to fair labor practice. The university as an institution has to fulfill its core mandate on teaching and learning, research, and social responsiveness. And to fulfill this mandate, we do need staff and students to be face-to-face and have on-site connectivity and activities, as this remains a core component of our work. Next slide, please. I did refer to the key June 2021 notice that was published by the Minister of Employment and Labour. This consolidated occupational health and safety direction consolidates a number of different acts. It does move across the Occupational Health and Safety legislation, the Labour Relations Act, and the Employment Equity Act. And we at UCT have, since April 2020, addressed a number of interventions consistent with the acts that I've just mentioned. And I'm just mentioning a few, including our COVID-19 risk-adjusted approach, where we've had to return to work using a particular kind of framework. And certainly we have had access control on campus and off campus, just to mention a few. The June 2021 directive clearly allows for employers to have a mandatory vaccination policy according to certain prescripts. Next slide, please. Employers who choose to apply a mandatory vaccination policy must fulfill certain criteria. They must make sure that the policy is fair, transparent, and accessible. We must ensure that there's an opportunity to vaccinate and it's easy and accessible. Employers need to make sure they have a reasonable and justifiable reason for implementing the policy, and without doubt, balance staff members and others' constitutional rights when implementing the policy. Next slide, please. Employers are permitted to implement a mandatory vaccination policy by doing the following things: to conduct a risk assessment, and based on that risk assessment, develop a health and safety policy and plan. We would need to take account of existing union agreements in this vaccination policy and plan, and certainly consider the Bill of Rights and potential limitations as specified in that bill. In order for us to be compliant with considering the limitations on Bill of Rights, we need to follow the prescripts of the Annexure C guideline in that gazette. Staff and students, and in this particular instance it's staff, have justifiable grounds for variation, i.e. a refusal on constitutional or medical grounds, and the employer, UCT, needs to provide for reasonable accommodation for staff members to continue to work while unvaccinated. It is clearly a matter in the policy and also in its implementation of balancing the overall good for the public and indeed considering individual rights. Next slide, please. In implementing the policy, the Vice-Chancellor referred to the fact that only Council can approve a mandatory vaccination policy, taking account of the views of the university community. The stakeholder engagements thus far have included the Executive supporting mandatory vaccination, the Senate September recommendation, and we continue to engage in various fora to date, the staff meeting today, the student meeting tomorrow, and formally getting feedback from our Labour constituency. Next slide, please. A reminder to all the colleagues in the room in terms of the Senate resolution, which importantly asks Council and the Executive and the Senate to establish the relevant logistical and operational features required to implement this mandate. And I spoke about what is needed from an employer provided for in the June 2021 directive issued by the Minister of Employment and Labour. In addition, the Senate mandate speaks to establishing systematic principles, rules and guidance that deals with the issue of exemption as is required by the June directive or specifying alternatives to COVID-19 vaccination mandates. The next slide, please. Of information to everyone is that this is not just a UCT matter. Many universities in South Africa are mulling over the policy directives. There have been issues and directives and policy frameworks from the universities indicated here, including Stellenbosch and the University of Wits, and USAF has also indicated their support. Next slide, please. There are also international universities that have addressed the issue of mandatory vaccination. I think we can skip over this slide, thanks. So in summary, the UCT approach to vaccination remains that we continue to encourage all students and staff and community members to voluntarily vaccinate. It's a pro-vaccination campaign. Our UCT Vaccination Center of Hope provides easy access to staff and students and other community members. And we have already facilitated access to other vaccination sites through providing transport and time off, and that we remain committed to. The UCT mandatory vaccination policy development process involves engagements with policy stakeholders such as we're doing now, feedback to the Council in October at our 16th October Council meeting, and clearly a mandate to then look at establishing the logistical and operational features that are necessary to implement this mandate, taking all the relevant legislative prescripts into account. Thank you, Vice-Chancellor. That would be the end of my presentation, and I'll hand back to you.
All right, thank you very much, Reno. We have a lot of questions, and I think as you were speaking, some of them, Reno, you responded to, some of them Linda Gale responded to. So I'm going to be selecting at random, just randomly all of them. There's a question here that says, I'm asthmatic and worry about the vaccination injecting COVID into my body. What if I have a bad reaction? Is it possible that I end up getting very sick from the vaccination?
I'll pick that one up. Thank you, VC. The vaccine does not inject the virus into anybody's body. I also saw a previous comment about a pregnant woman and the worry about, you know, offspring. To date, the vaccines have been administered with strong recommendation from every body that is licensed to look after pregnant women or breastfeeding women, including our own obstetric groups here in South Africa. The reason being that the risk of COVID itself in pregnancy and to the unborn baby and the neonate are much greater than anything we've seen with the vaccine. In fact, we have not seen any problem in pregnant women with vaccination, and that is Pfizer as well as other types of vaccines. So we are making a strong recommendation that vaccination should be offered to women who are pregnant or breastfeeding. To get back to the fact that the vaccine does not actually inject SARS-CoV-2. The way it works is it sends a template, if you like to think about it, it's an email, and when it gets there, it actually then shows the immune system picks up, and then it disappears. So it is not something that sticks around in the body ad infinitum. And so that is important. And, you know, to reassure people that overwhelmingly what we see is a little bit of reactogenicity at the time of vaccination, much like any other vaccination. A day or two of feeling a little under the weather, maybe a sore arm, that is it for the vast majority. Now, there are a couple of associated adverse events that, as has been pointed out in the chat as well, worry about clots. Extremely rare risk of that happening, or on the case of the mRNA, a heart inflammation, particularly in younger people, again, short-lived, transient, and very rare. So we are very aware of these, again, making the point that millions and millions and millions of doses have been administered, which helps us pick up these very rare events, and reassures us that still the benefit of the vaccine far outweighs the disease and the risk of the disease in contrast. So I hope that answers.
It does. Reno, just to connect with the question that Linda Gale has just responded to, someone is worried about whether UCT will take responsibility for their health. Should they have an adverse reaction to the vaccine, since they'll be doing this against their will?
Thanks, Vice Chancellor. I think the way we would approach it is that we have a duty of care, and certainly in terms of providing the safest, best possible, most efficient way of doing something, we will follow all the necessary requirements, both legislatively and otherwise. I think the issue of legal liability is a vexed one, but certainly our efforts and the legislation in healthcare is also about doing the best you can, reasonable accommodation. Because just if you think of other interventions in healthcare, there's no 100% intervention. So it's taking all of those things into account and doing the best we can as an employer and working with the Department of Health and other providers. But that would be the intention of the university. The issue of legal liability is a tricky one, and certainly I suspect, like with other matters in medical legal issues, we would have to walk the journey on that one. I don't think it's an easy answer. Mm-hmm. I think David Kutsia may want to assist in answering that as well.
Yeah, I should have made colleagues aware that we've got Associate Professor David Kutsia and Dr. Tracy Naledi who are on the panel, and I'm going to ask them to switch on their cameras so that they're also visible here, because they'll help answer some of the questions that come up. There's a question here that says, according to the FDA, the vaccine efficacy wanes after 2 months, and it's only effective for 6 months. The FDA warning states that the vaccine does not protect all people, which covers the vaccine maker for anyone not being protected. So effectively, we are fully covered for more than 6 months at a time with the vaccine, and after 6 months, we are not covered. Why then force something into our bodies where there is no actual protection? How many shots are we going to have to take once the efficacy wears off? We can't hear you. David, do you want to speak to that, Linda? Yeah.
If I may, I'll quickly pick up on the boosters because it obviously is very topical at the moment. So let me be very clear that the waning people have been seeing has been in the laboratory. So that has been, antibodies that have taken a bit of a downturn, and that's been really in a large number of the vaccines after 6, 8, 9, even in some cases 12 and 13 months. In the elderly and in people with immune compromisation, we are seeing in the laboratory a reduction in those markers of immunity. We have not seen a fall off in the protection against severe disease and death. So that's important. These countries are moving to boost, first of all, because they have more than enough vaccines, and so they can, and they are looking to up and enhance the protection against all infection, including even just symptomatic infection. So remember, that's our secondary aim, and they are moving to boost to do that, to protect the elderly, to protect the immune compromised, and to enhance vaccine efficacy across the population. It is not necessarily a requirement yet to have that boosting. And as I say, I think it is more a luxury in these countries because they have access to vaccines. I didn't concentrate on it because our first goal is to make sure that everybody in the country gets at least their prime vaccine. So the first sort of dose, 2 doses if it's Pfizer, 1 dose if it's J&J. Let's get as many people that are in that category as we can as soon as possible, and then we may think about boosting. Now, how often is that going to happen? We don't really know how often we're going to have to do that, but it's, think about flu, think about tetanus, think about yellow fever. This is kind of the norm when it comes to vaccines, and it's because our immune systems don't hold forever, and viruses can change, and this is why we have to think about boosters down the pike. But it's likely to settle into a pattern where it will maybe be annual at the minimum. We're going to have to see what that looks like, but it's going to get easier. It may be that you could use a smaller dose for your boost, which is very encouraging, the way Moderna has done. And so these are the things we're going to have to figure out down the pike. The most important thing we do is that everybody gets some level of protection as soon as possible and en masse. That is really the most important goal.
Thanks, Linda Gale. I didn't indicate that David is a public health specialist who works in Dr. Mora's office on COVID-19 projects for UCT. And Dr. Naledi is Deputy Dean of Health Services in the Faculty of Health Sciences, and she's got more than 20 years experience in government and NGO health matters. So we invited them because we wanted public health specialists who can talk to the issues. And so David and Tracy, feel free to interject as and when necessary. Someone is asking, why does anyone need to vaccinate if they've contracted the virus before? Surely the argument of antibodies is a sound one. Is it really?
Yes, I think it's an important question, and certainly you do get, as Linda Gale already mentioned, very good protection if you have been infected with the virus. It's really good, but it's been shown, and I think you mentioned this as well, Linda Gale, that with having the vaccine as well afterwards is even better. So it's in order to get the strongest immunity you can possibly get, and that's why even if you've been vaccinated, even if you've had COVID, we think that you should be vaccinated as well. Linda Gale, I don't know if you want to add anything.
Yeah, Dave, I would just add that we do see that immunity wane against what we call convalescent. So that is somebody who's recovering after infection. Their antibodies also start to take a downturn after a period of time. And what the vaccine does is it just zhuzhes it up and gets it right back up into those top levels. So you almost get your boost right there. And so I can speak personally about this. I have been infected with the beta variant. I was very glad to get my J&J shot. And I promise you the disease itself was far in excess of the vaccination in terms of any impact. But I now know that I'm extremely well protected, which is very reassuring given the work I do. So that's a personal sort of testimony.
And how does a recovery rate of 95.6% in South Africa justify a forced injection? And of course, someone asked also in terms of a recovery rate, and is saying, did more than 99% of people also survive the Spanish flu? Anyone?
Yeah, I mean, what I would say about the Spanish flu is that a lot younger people died in that one, which I think was devastating for the population. And I used the illustration really just to show that people have lived through that kind of devastation before with enormous impact. That really affected everybody in extraordinary ways, and we have felt the impact. Mental health, loss of life, loss of earnings, the economy, and in the shape it is, all of that has had enormous impact for us too. We now have the wonderful bonus, gift if you like, miracle of vaccination, and what we're saying is we should not spurn that opportunity to turn our epidemic around, at least having got to this point. So that question of, well, if most people recover as they do, how do we see benefit here? Well, on the one hand, you've got the restrictions, the lockdowns, the difficulties, and on the other hand, you have a return to normality. And the door that you have to walk through to get to that is called vaccination. And that is what we're putting on the table here, is that vaccination does have that secondary bonus of saying that you can reduce the amount of infection in communities, thereby not requiring the restrictions, the lockdowns, and the NPIs. So it's a simple formula, in fact, at the end of the day, to try and get ourselves back to where we need to be.
There's also the impact on the health services, keeping other people with other conditions out of hospital. So we've got those deaths as well. And so it's had an enormous impact on our health services. And I think we must recognize that, as well as the economy, unemployment, all those sort of things as well.
I just wanted to add with regards to the impact and talk a little bit, as David has said, around the impact on the health system that we are aware of. And I think it's a little bit too early for us to be able to pick up, in fact, some of the consequences that we are likely going to see over the next 2 to 3 years in terms of the impact of our other epidemics, HIV, TB, diabetes, hypertension, because in fact, what's happening at the moment is that the COVID pandemic is replacing. You must remember, we've always had a fixed health system that was already struggling to cope with the burden of disease that we've had. We have now overlaid on that the pandemic, COVID pandemic. So what has happened is that we've actually displayed the capacity that has been there within the health system. So the consequences of this, we are still going to feel down the line. But what we know for sure right now is that in the last year, we have reduced our life expectancy by 1/3. Just to give you context of what that means is that it took us 10 years to build, to increase that life expectancy that had been decimated by the HIV pandemic. It took us 10 years to build that up, and it was taken away from us in just a year. And with regards to the economy, we know that our own economy, GDP reduced and unemployment increased by about, GDP reduced by about 80%, as far as I understand. And what is even more disturbing to know is that the World Bank projects that the high income countries will recover By 2022, most of the high-income countries would have recovered, but for us, it's only a third of kind of low and middle-income countries that are projected to recover by 2022. So the consequences of inaction are actually quite significant.
Reno? You are muted, Reno.
Thanks, Vice Chancellor. I wanted to pick up on the comment Tracy made, because we also want to bring it close to home, our institution, you know, what our core mandate is, and the way in which we teach and learn and research and do our social responsiveness programs. It is a combination of in-person connectivity and remote connectivity. And we do want to make sure that we get back to normality as safely as possible, so that our community experience the true value and output of an academic institution. It is core. Many parts of society have been affected, notwithstanding how we have been affected. So I think the drive for people to get back to where we should be is very consistent across the sectors. And importantly, we are a public academic institution.
Obviously, we won't be able to go back to where we were, but we want to go back to somewhere where we can feel comfortable that we are offering the education that students come for here. Let me ask another question that is related to this. Someone says, is the intent of the university to ensure a COVID-free environment? If so, surely we would need to know the status of all people vaccinated, whether they are vaccinated or not. Being vaccinated does not mean you cannot contract or transfer the virus. In fact, asymptomatic people, vaccinated asymptomatic people, will covertly carry this virus, submitting it unawares. Linda,
yes, you know, just to again reiterate, and I apologize, I saw that comment that our presentation should be more translational to the broader community, so I apologize if I was technical, and happy to have more conversations offline with individuals to try and get the messages across. But the message that I want to say here is that if people are vaccinated, we see a reduction in transmission overall, because what this means is you are less likely to incur the infection yourself if you're vaccinated, and you carry the virus for a shorter period of time. You can only transmit whilst you're carrying. So if you are carrying, you are less likely to transmit. You're right, if you are completely asymptomatic, you may do it inadvertently, but at least that period of time is going to be restricted. And if enough people, and that was the attempt of that diagram, if enough people are vaccinated and you add all those benefits together, you have a general reduction in how much virus is circulating in that community, and ultimately you eventually do away with it. And that's what has happened with with polio eradication programs, etc. When you get enough people up, then you just reduce how much transmission is happening across the board. So should we know one from the other? Yes, I think if we don't have a mandate, then maybe, the alternative is you have to say, you can come into my home, you can come into my office, but you need to be vaccinated, which is obviously really very tricky, because that then becomes, a conversation that you have one-on-one with individuals, or you check with your classroom, or you check with the staff. And certainly, this is not something we can do, for example, in hospitals. You can't say, we'll have these nurses who are vaccinated and we don't want to have these nurses who aren't vaccinated. The point is, if everybody goes out and gets vaccinated, then that becomes moot. You don't have to do that kind of head counting anymore, because we have the assumption that we are a community now who are entirely vaccinated. And that really is what we want to aim to. Again, I'll say this, preferably voluntarily. But if we can't, if we have to do this quickly, which we believe we do, we have to get to this place as quickly as we can to derive benefit. We have a predicted fourth wave coming. this, this strikes fear into all of us if we have to face again the restrictions we faced with the first, second, and third waves.
And I think what Linda Gale is saying is worth emphasizing, the time. Because I think if we had time, all the time in the world, we could have more conversation, we could try and convince people. And I think for me, that's one of the most important rationales for mandatory vaccination, because evidence actually shows that if you convince people, all the social mobilization, yes, it does increase uptake by about less than 5%, 2 to 5%. But if you do introduce a mandatory vaccination, that goes to about 20 to 25%. And so I think, especially in this context where we actually don't have time, and as I said earlier on, the consequences of not doing anything are so dire. I think from a public health perspective, from a population health perspective, it is so important that we do this now.
Thank you. Many have experienced severe side effects after their first shot of Pfizer vaccine and have voiced their fear or reluctance to return for the second jab. What are the implications of not returning for their second jab?
So without doubt, we don't want to encourage that. The trials are based on a 2-dose regimen. However, a number of studies have looked what is the benefit of the first only. And so definitely you get some benefit from the first dose. And so I would celebrate that at least 1 dose is in. And so that is better than nothing, as said. But remember, if you are older or you have some immune compromisation, and that, might be just simply getting older. We know that from about age 20, our immune systems start to get old. You are not getting the best benefit out of the vaccine. So that second dose fully protects you and make sure that you get up into that 85 to 90% protection against severe disease and death. You are right, there are those few individuals who don't have take in the first go, and this again is the benefit of repeat vaccination, because those individuals who don't have a take, and there are very few of them, but in Sisonke we are aware there are some of the healthcare workers who did not see a response. We did not see a response, but on the second dose or a booster, they had the take and were again protected. So I can also reassure that what I have heard anecdotally is that if you did have quite a lot of reactogenicity in the first injection, it is reduced in the second. So that is good news. In addition, and if we can just wrap our heads around reactogenicity, we all vaccinate our children. They have a little fever and they feel quite grim. We can see it in our small children when they get vaccinated. That's really essentially what we are going through. And it is reassuring. It is that your immune system is actually responding and is, taking on the defense that it needs to have in order to protect you. So if we can just get ourselves through that reactogenicity, it is worth it for the value of the vaccine down the road.
All right. Someone is saying they would like to request a definitive proof of degradation of natural immunity, as there is currently still no conclusive answers around this.
I mean, I can send laboratory-based studies, that I'm afraid they are out there. There are studies showing that there's waning immunity. And we know that individuals who were infected with the Wuhan strain or the ancestral strain got the beta strain, and some sad individuals have had 3 goes of COVID. It is what it is. So, I think we can strain at the gnat, but there is actually laboratory evidence. Happy to share some studies with the individual as required. I didn't want to put too many into a presentation, but those are available also on Google if you want to go and check it out.
And this person says, how do you then explain the 100% increase in cases and deaths in almost fully vaccinated Israel?
So this, and I hear this all the time. Israel is about number 70, I think, in terms of countries that are well vaccinated. They got out of the starting block first, but they have not done well in covering their population completely. I think they're sitting at about a 60% coverage at the moment. And what I tried to show you in that diagram is if you have gaps, and it speaks beautifully to what we're trying to say here. We want to create at UCT a tight community where we have almost 100% vaccination, because that is protective. The minute you have gaps in immunity, the virus exploits those gaps. And that's exactly what has happened in Israel. They had gaps, a new variant came in, and it overwhelmed their situation. And it was sad that the Delta came in at a critical time. They still sit at about a 60% coverage. I don't know who they're vaccinating in the community, but they're missing 40% of their population. And that is why we have to aim for a scale up of our vaccine. I can't agree more with the colleagues on the panel. This is absolutely key and urgent.
All right. I don't know, maybe you can help with this one. Most people are not necessarily discarding the fatalities caused by COVID-19. It's the stripping away of people's choice, their right to choose. I'm pro-choice. And secondly, the science behind COVID-19 contradicts itself as well. How are unvaxxed people a threat to those vaxxed? Isn't vaccinating supposed to boost your immunity towards the virus, thus landing you on the safe side? How are the unvaccinated seen as a threat because it's their lives? The whole mandatory vaccination thing seems dubious to those unmotivated to vaccinate. And to make matters worse, by clamping on their freedom as a means to force their hand, resembling the apartheid regime, educate people about it rather than forcing people's hand to vaccinate against their will. I'm sure you can all talk about this.
Yeah. I'm happy to start.
Yes.
Yeah, I think I mentioned early on in my presentation about the duty of care, and the duty of care does involve, and it does happen in many settings. On mandating, the duty of care takes account of the overall public good, recognizing that there are individual freedoms within that. And we are thankful that the Constitution and other parts of our legislation makes us as an employer, makes sure that we balance those things in terms of the broader public good and individual freedoms. The intent is not to ride roughshod over any individual freedoms. The intent is to ask, as a population, as a group, as a nation, as a community, what is in the best interest of all of us relative to our personal beliefs. In addition to that, the June 2021 directive requires us to demonstrate the duty of care in terms of how we deal with justifiable grounds of objection, on medical grounds, on constitutional grounds. And I have faith that the university as an entity, the university as a community, and remember the Senate resolution also asks that a group of panelists participate in framing how we balance those population, community, public good rights with individual rights. So that's the way I think as a community we should approach this year. On the more specific issues on the vaccinations, I'll leave that to the experts in the room. Thanks, Vice Chancellor.
Mm-hmm. VC, if you will indulge me, I'll use an analogy which helps me. And if it's too simple, I hope that people will forgive me. But this is how I see it: is unfortunately, the COVID vaccines across the board are not impenetrable fortresses. In other words, they are not 100% preventive. If they were, then yes, I got vaccinated. I don't really care what happens to the rest of the world. I'm going to be okay. And it's my business. But the problem is if you like, and I'd like to think of this as we have a hedge that we put around ourselves that is not completely head high. It's about this level. So when SARS-CoV-2 comes in, a good amount of the SARS-CoV-2 gets prevented from reaching me because I have my hedge, but some of it could reach me and cause me to have milder, but still get infected. Now, if we have enough of us with hedges around us, even though they're not 100%, if there are enough of us, then enough stopping of SARS-CoV-2 will happen that we will overall have better protection across the board. So this is really what I'm trying to show, that secondary benefit is what we are aiming for here for our institution, that public good and public benefit, which overrides or is more than the individual benefit that you are going to derive from being vaccinated. And that is where, if those hedges don't come together, if you like, in this kind of way, because we've got gaps, then SARS-CoV-2 comes in more effectively. The level of viral load or the amount of virus circulating in the institution will go higher. And then those viruses that can get over my hedge will increase. So your gaps has an impact on me down the pike. So I'm hoping that this analogy, which I use and I use to sort of try and teach other people, might just help others understand that it's the secondary benefit we're aiming for here.
And I don't know, if people feel not ready and they don't get vaccinated and we come back to campus, will they be fired? That's another, several people are asking that.
Vice Chancellor, the prescripts of the June 2021 directive requires us to be a good employer. We would not, under other circumstances, just fire people willy-nilly. And so the ethos of a good organization that looks after its staff and students must go through mandatory vaccination as well. There's a very prescribed way in which we in the past have dealt with incapacity in terms of the Labour Relations Act. We will continue to do so. We are wholly committed to have processes and procedures that are legally and socially justifiable. There is, at the end of it, a difficult decision to make where, like with other health conditions, it is difficult to find the reasonable accommodation. It is a reality. What we are not in the business of is to fire people just at willy-nilly. And I think that's the commitment that this university needs to make, has made in the past, and will continue to do so. We will make sure that we follow all that is necessary legally and socially. It's our duty to do so.
Thanks, Selma. And how do we know if there are no long-term effects? Some people are worried about long-term effects of the vaccine. Any long-term effects? How will we know, Linda?
So that is a valid point. And, you know, we've had these vaccines, they started, the genotype was discovered. I saw some Twitter feed the other day that the genotype is not known. That is not true. It has been found many times by many laboratories around the world since about the 10th of January, when the Chinese first put the genotype out on the public arena. Vaccines started to be research and development started immediately. And as you all know, Pfizer received its EUA just before Christmas or so of last year. We then have seen multiple millions of doses administered. And so we are literally gaining tons of knowledge as time goes, but we have only had these vaccines as long as we have had them. Having said that, they are built on platforms of vaccines that are a long time. And we know that those vaccines have not, caused irreparable damage and harm down the road. So in that sense, vaccines, and this is why we administer millions of vaccines for a slew of diseases every single day, including to our children, because we know that they are, in terms of their pharmaceutical impact, light, and yet they have huge benefit in terms of preventing disease and problems. So we are reassured that unlike some of the pharmaceuticals that people have been trying, the vaccines generally have a very good long-term health record, if you like, in terms of safety. And so that is what we are relying on, and we've had no indication to date that we need to think otherwise. And certainly that goes for fertility and for reproduction. There is no evidence that we have to worry about that in this regard or with other vaccines.
Then another person says, if mandatory vaccinations are approved by council, will we social distance in venues? If so, this does not allow us the benefit of going back to normal on campus. Rena, will we still be required, or David, I should ask David what your advice would be to the CCC?
Okay, well, first of all, we don't really know what proportion of our population is vaccinated at the moment, and it would be very hard to be able to get that. We have even spoken to the medical aids, and they're very reluctant even to give us an aggregate figure. So for staff, obviously that would only be for staff. So we don't really know what the level is. So we would need to keep in place all our non-pharmaceutical interventions until we have some evidence that we've got a good rate of vaccination on campus. We couldn't just suddenly throw away all those interventions that we already have in place. So that would be my answer. As soon as we could get some assurance that a large proportion, a very large proportion were vaccinated, we could consider those regulations and those interventions that we currently have on campus.
All right. Rena?
Thanks, Vice Chancellor. I think it's a combination of all that we have in our toolkit and to use it to its maximum benefit, including pharmaceutical interventions, as well as mandatory vaccination. I do want to come back to the point you made earlier, though. It is a return, not to the normal. It is a return to a new normal. And I think in that spirit, we need to be able to find the right balance between on-site connectivity and off-site connectivity. So I don't think the approach should be, well, if we don't have all of this in place, then we shouldn't return to campus. I think the approach is that with all of that is within our disposal, we need to find a new way of working. In my understanding, and Linda Gale and others can confirm it, the virus will be around for quite a while to come. It's therefore incumbent on us to learn to live with the virus in ways that makes life more sensible, makes our academic project the way that we want to achieve the best outcome. That would be my view on the sort of new normal approach.
Thank you.
Most of our interventions thus far have kept the campus pretty safe up till now. So we haven't had many cluster outbreaks on campus, and we've had a very good response team, and that will still be in place. That won't change at all. That will all remain in place, and we will try to have a very safe campus, but with greater numbers and gatherings and things like that. But we will still be careful.
Yep. All right. UCT is huge on mental health. How do you think taking a jab against my will affect me psychologically?
Again, I think, our role here is to weigh up risk and benefit all the time. And I would say to that, VC, it's an important question. We're all very concerned about mental health well-being. We are very concerned about the mental health impact of the restrictions and the difficulties of the last 18 months. And we know that some of our most disadvantaged students and some of our staff who struggle the most have been most affected by the restrictions and the difficulties. And so really we're weighing up a shot in the arm, against all of that difficulty and are deciding without doubt, again, the risk-benefit ratio falls strongly in favor of vaccination. And that is our, undoubted stance on that.
And I think it's important, VC, just to, on that question, that it is not our intention, nor are we legally allowed or medically or ethically allowed to vaccinate anybody against their will. So I think it's quite important for people to understand that what we're talking about here, when you're talking about a vaccine mandate, it is absolutely not about vaccinating people against their will. We are hoping that we will convince people of, as Linda Gale was saying, the benefit of vaccination for themselves and for the community, for the public good, and for the health system, and in particular to protect those that are not able to vaccinate. As Reno said in his presentation, there will be those for multiple reasons who are not able to vaccinate. So I think it's important for people, and because I've also heard this over and over again, when people talk about mandatory vaccination, then they talk about forced vaccination. It is not the same thing, and that is not what we're saying.
Can I also add that the mental health of people who've had COVID, we've seen this in our long COVID group, it's a really, really an enormous problem, the mental health issues. Not only long COVID, just having COVID and deaths in the family and all these issues. Certainly that outweighs, the benefit of the vaccine outweighs that totally.
Someone says, I strongly support mandatory vaccination for COVID-19. How will the university be able to tell the difference between a legitimate and illegitimate reason to not take the vaccination? How will we know? Linda?
Yeah, I mean, my response to that, VC, would be, and I think this was one of the recommendations that we, sort of included in the proposal that we discussed the other day in Senate, is that, a committee is put together that has people who understand the technical side as well as the social as well as the legal aspects of this, and that each case is interrogated in its own right, case by case. And I really can't think of any other way of doing that it will need to be not an individual making a decision, but a committee who are entirely objective and take this on with some guidance and some guidelines in order to carry that out. And I'm seeing head nodding from the other panelists, but I think those details will be worked out in the next few weeks if indeed this is the way we go.
Mm-hmm. Tracy, you covered?
Yeah, covered.
And what if will UCT take accountability should I die from the vaccine or get chronic illnesses in my later ages? But Reno, I'm also thinking in terms of occupational health and safety. When if we bring people on campus and they're not vaccinated and we have an outbreak and some people die, I mean, I want us to look at it both ways, because I think people only look at what if people die after the vaccine, but there's also the question of what if there's multiple deaths on campus and we haven't even done anything about the vaccine. So is the 16.1's job on the line?
Vice Chancellor, I think you have hit the nail on the head, a difficult question, but a good response in the sense that we, in our duty to look after and protect staff, students and visitors, we have a responsibility to do so. It fits very well with the comment Linda Gale made about weighing up the costs and benefits. So we have a responsibility for the whole. We need to exercise our minds and apply that in a way that protects the whole. There are individual cases, and I think again, it's going to be dealt with on a case-by-case basis, but we cannot not take up our responsibility and hide away from it and fear from it. because there may be individual cases that need to be dealt with on a case-by-case basis. So the direct answer to 16.1, the Vice-Chancellor is tasked with looking after the university community. We as part of the team are also tasked to do so, and we must do everything in our power to make sure that our environment is protected and safe for staff, students and visitors.
And Rena and VC, I would just reassure you that the former, in terms of deaths from vaccines, are going to be vanishingly few, if any. In fact, I would hesitate none. Absolutely none would be my way forward here. Whereas if we have outbreaks of COVID on campus, we are going to see morbidity and death, unfortunately, because that's the way this epidemic and this disease rolls. That is the truth.
Yep. Thank you very much. I see that we have run out of time, but I also wanted to say to colleagues who are on the call, I mean, we've seen many of your comments, more than 500 of them. We will collect them, read them, analyze them, and so that they are featured in what we submit to council. Obviously not each one of them as it is, but they will be considered, all of them. Just to say that, I mean, this is the university asking us to get vaccinated so that we can get to a position where we can have face-to-face life in the university. But you will notice as 2022 starts, and many of you would have noticed it by now, that no event, no face-to-face event takes place without a requirement to produce a vaccination certificate and also a COVID test. I mean, any conference, if they don't ask you, it is very irresponsible, because the conference organizer is the 16.1 in that case. And there's a conference overseas. I didn't go, I attended online, and I've been reading the frantic emails that the 16.1 there, whatever they call them in that country, that the responsibility that they are having because one person tested positive. It's not like they're critically ill, they're whatever, but their country holds them responsible. They had required everyone to come with a vaccination certificate and a COVID test, but something happened. One got what they have to submit reports. They are held accountable. So what I'm saying is that what we are doing here is going to be a normal requirement in many spaces. We don't know how long it's going to go before we are not required to produce those, even in public spaces. We don't know. But I don't think you'll be able to do any conference face-to-face or any meeting face-to-face without that. So we are doing our jobs in this way, and not requiring you to vaccinate will be very irresponsible on our side to have so many people on campus. And we call you to come back to campus, and there isn't anything that we do. You want to add anything, Reno? I see you. No. Okay. So thank you very much, colleagues. Let me thank all of our speakers, Dr. Mora, Dr. Naledi, Professor Linda Gale Becker, and Professor David Kutse. Thank you so much for always being available, for being of service even outside this meeting. Of course, we did not have time to discuss everything that people contributed, but it's good to have these contributions. And colleagues, please be assured that the executive will consider all your contributions as part of our discussions on vaccination policy. I also want to thank CMD for organizing and managing this event, and as well as ICTS for their expertise in managing the technical details behind the scenes. Please, colleagues who are attending the meeting, please remember to complete the very short survey on your views on a proposed mandatory vaccination policy. The link is in the meeting chat, as I said at the beginning of the session, and the survey will be available until 6 p.m. on Thursday, this Thursday. We need to have those responses so that we can have time to prepare a document for Senate. So if you have not been vaccinated yet, I encourage you to do so, because that will help keep down the rate and the severity of COVID-19 infection, not only on campus, but on any other space that you occupy. You and members of the general public are welcome to visit our UCT Community of Hope Vaccination Center at Forest Hill. And you can get vaccinated. The queues are very short. Feel free to go there. The site is open Mondays to Fridays from 8 a.m. to 3 p.m. Thank you very much, colleagues. Enjoy your day.